afternoon, everyone. My name is Jack, and thanks everyone for attending the next installment of the APSC CME webinar. Today is our Cath Lab Fellows teaching session using OCT to optimize the treatment of calcified lesions. The date stamp today is the 28th of May, Friday, 3 p.m. Singapore time. This event is organized by the APSC, endorsed by the Singapore Cardiac Society, the Asian Pacific Society of Interventional Cardiology, the Hong Kong College of Cardiology, hosted at Sengkang General Hospital, in close participation with TCIP, accredited by EBAC for CME points in proud collaboration with Abbott. My name is Jack. I'm an interventional cardiologist from Singapore, the current president for APSC, as well as ICP. I'm very privileged to have my co-chair, Professor Takashi Akasaka from Japan, as my co-chair. We are also very privileged to have this event conducted in Sengkang General Hospital, our kind host. The first speaker for today will be Professor Takashi Akasaka. He's going to speak to us on the importance of coronary imaging on calcified lesions. This will be followed by Dr. Anuruck from Bangkok, Thailand. He's going to talk to us on OCT, the MLD max algorithm, treating the lesion right. Our next speaker is Dr. Alan Chan from Hong Kong. He will narrate to us the tips and tricks on OAS, shockwave therapy on calcified lesions. And last but not least, Dr. Lim Eng Han from Singapore will have a finishing lecture on IVUS versus OCT on calcified lesion. Does it really matter? Our live case operator today will be my good colleague, Dr. Fan Jianming, as well as Dr. Mohammad Idu. They will be operating on the case, and our live OCT interpreter and operator is Dr. Chin Chiang, also another good colleague of mine. The panelists for today, good friends here, Dr. Donny Furman from Indonesia, Dr. Rosli Muhammad Ali from Malaysia, and Dr. Sengo from India. The coordinators for today are Dr. Keryan San as well as Dr. Wong Ning Yen. This webinar is copyrighted by the APSC and should not be distributed without the prior permission of the APSC. The views and opinions expressed in the webinar are those of the faculty members and do not necessarily represent those of the APSC. Housekeeping, the live content is currently made live via Wonder, APSC Facebook and YouTube pages. For Singapore registered physicians, CME points will be submitted for attendees who are connected throughout the whole duration. EBAC grants CME points for regional attendees who attend the full session. You will receive your certificate of attendance upon completing a survey sent by email post webinar. And if you have any questions at all, please type in the Q&A boxes. We'll endeavor to answer all of them. A pitch for upcoming webinars on the 23rd of June, 6 p.m. We have an APSC Emerging Leader Journal Club on anti-thrombotic regime in AF patients undergoing PCI, where we'll critically appraise and teach regional participants how to look at journal articles. 24th of June, 2021, we have another webinar on overcoming complexities when bleeding just doesn't stop in our patients. So I want to state the learning objectives for today. One, we want to understand why coronary imaging is important for calcified lesions during PCI. We want to dive into the MLD max algorithm, how to treat the lesion right. In treating calcified lesions, we want to understand when is atherectomy adjuncts required. And lastly, the difference between OCT and IVUS on calcified lesions. Does it really matter? So let's get started. And I would like to welcome Professor Akasaka to give his opening lecture on the importance of coronary imaging on calcified lesions. Prof. Akasaka, please.
Yeah, thank you very much, Jack, for kind introduction. And it is really my great honor and pleasure to be invited this lecture. I tried to share my slide. I could not find my slide. Wait a moment. Right.
Don't worry, it's more difficult than doing PCI sometimes.
No, thank you, Jack. Right. Take a little bit time. Wait a moment. I'm very much sorry. Right. Yeah. Try to share share my slide. Okay, yes, this one. Yes, can you see my slide? Okay,
Yes.
yes, yeah, I try to do the, yeah, slideshow. Yes.
Thank you, Prof.
Yeah.
Very clear.
Thank you. Later pointer. Yes. Yeah. Today my talk is importance of coronary imaging on calcified lesions. Yes. This is my disclosure, right? As you may know very well, in case with stable angina, severe tight lesion calcification is associated with an increased risk of adverse cardiovascular events following treatment with second generation DS compared with no severe calcification as shown in this slide. And this is another slide. As you may know, a patient with severe calcification had significantly worse outcomes compared to those without in a MI, TVR, MACE, as you know very well. So that is the reason why we have to pay attention to the calcium. There are many yes, modalities to identify the calcium, coronary CT, angio, and IVAS and OCT. Compared with IVAS, OCT can evaluate the thickness of calcium. It might be the advantage when you treat the lesion. So this is another data showing the comparison between among angiography, IVAS, and OCT. Angiography visible calcium seems to be a marker to predict the stent under expansion previously, but IVAS is much more sensitive to identify the calcium more than OCT, sometimes because of the plaque attenuation and penetration depths of image in OCT. So, but in a case with PCI, the superficial calcium is the most important. Therefore, the OCT might be a wonderful technique to identify the presence and the distribution and the information of the thickness. Right. So this is the relation between calcium eccentricity, thickness, and length and stent expansion. Even in case with circular calcium, if it is thin, we can make a fracture of the calcium and we can obtain the good lumen area after stenting. But if the calcium is very thick, but it is localized, we can obtain a good lumen area after stenting because the other portion will be expand. However, the nearly circular or more than 180-degree eccentric calcium, it might be very difficult to obtain in the full expansion as shown in this slide. And if you try to dilate more, there are some risk of rupture in the other site. Therefore, identification of the calcium is very important to treat the complex lesion, as you may easily understand, right? I'm sorry, the slide doesn't move, right? Now, wait a moment. Yeah, and the other mechanism of the poor prognosis of the tight calcium lesion with DS is explained by the polymer damage. If you try to push in DS aggressively through the calcified lesion, you can identify the polymer damage as shown in this slide. This might relate to the poor prognosis. So it is important to do the lesion modification by the atherectomy device or shockwave or some other modality, right? So let's start the case. The 60 years female effort angina patient have the plan to have a colon cancer operation, but she had a angina. The surgeon sent to us to check the coronary before operation. And this is the angiography. You can identify the very tight lesion with the severe calcification and any kind of modality, including imaging modalities through the MLD side. Therefore, we did a rotablator 1.5 millimeter bar for lesion modification as shown in the right-hand side movie, right? And this is the result after a rotablator. Here is a tight lesion. After rotablator, we can obtain the round shape ablation lumen with still significant thick circular calcium. Therefore, we decide to bar size up to 2 millimeter. And this is a result. You can identify much bigger lumen. However, there are some site without any calcium. Therefore, much more bar size up should be the risk to make a perforation. Therefore, we did a drug-coated balloon inflation, and the patient had a colon cancer operation, and there are no problem, and patient is now very well. This is another case, 70 years old male, and the hemodialysis patient. The patient had a CABG previously, and recently she had a recurrent angina, and perfusion image demonstrate inferior ischemia. And this is angio. You can identify the calcium from the proximal to the distal RC and proximal LAD, from left main to the distal LAD. And you can identify a very tight lesion. And in this case, we did an IVUS first. Luckily, we can pass the IVUS, and we can identify the lots of calcium as shown in this movie, but we cannot identify the thickness of the calcium. Therefore, we did an OCT. You can clearly identify the circular calcium from the distal to the proximal site, as shown in this slide. Therefore, we did the rotablator. This is a still frame. You can identify circular calcium with some calcified nodule. And this is an after rotablator. We can succeed to make an ablation in the calcified nodule and some calcium part, as shown in this slide. And if you would like to put a stent, as I told you before, if the thickness of the calcium is nearly less than 500 micron, if you do the high pressure ballooning with a non-compliant balloon or a scoring balloon or cutting balloon, you can make a calcium fracture, as shown in this slide. If you succeed making a calcium fracture, you can put a stent to obtain the good lumen area, as shown in this slide. And how to speculate making a calcium fracture? The best cutoff is around 500 micron, but it's a very complex 3D distribution sometimes. Therefore, the 300 micron to 650 micron, yeah, and the range is a little bit bigger, but the best speculation, prediction of the making a crack is 500 micron. And if you succeed to make a fracture, stent area is bigger and stent expansion is better, and binary distance and TLR is significantly smaller compared with the case without any calcium fracture. And this is another report from Japanese colleague. They use a scoring balloon, and if the calcium angle is more than 270, the best prediction thickness of the calcium fracture is 535 in this report. Therefore, the similar data. Yes, also not only circular calcium, but also the eccentric thick calcium is a big issue in complex PCI. This is the significant stenosis at the proximal site of LAD, just the opposite side of the diagonal branch. This is an OCT image. Here is a diagonal branch and LAD, and you can identify the very, very thick eccentric calcium. If we put a stent simply here, we cannot dilate this direction. Therefore, the carina shift may occur to the diagonal side and diagonal may occlude. Therefore, if possible, it might be better to develop here, right? So we try to use an orbital atherectomy by using wire bias. And initially, we did low speed pullback way. and check the ablation possibility. Wire is here, and this is good. Therefore, we did a high-speed pullback several times and get a good ablation, right? And then we could put a stent, and the result is this, right? Great result. So I would like to recommend, if the calcium is circular, we can use the rotablator very safely, as shown in this slide. However, if there are a thick eccentric calcium, if we can use the wire bias, orbital atherectomy should be the better compared with rotablator. So the Dr. Fujino, when she was in CRF, they proposed the calcium scoring system using calcium angle and thickness and length. If the angle is more than 180 degrees, they put a 2 point, and thickness more than 500 microns, they put a 1 point, and more than 5 millimeter length, they put a 1 point. And if the score becomes 4 point, the result is very poor. Therefore, at that time, it is important to make a lesion modification using some ablation, right? And this is one of the recommendation to treat a severe calcified lesion. If you can pass the OCT, it is important to check the score. And if score is 4, you try to cross the balloon. But if the balloon crossable, you can use a shock wave and then a calcium fracture, making a fracture and put a stent. And if the balloon uncrossable, rotablator or orbital atherectomy should be used and to make a calcium fracture finally, and then put a stent. If score is from 0 to 3, you can use a non-compliant balloon, scoring balloon, cutting balloon, and finally you can make a calcium fracture and you can put a stent. But if the OCT is not cross, it is important to follow this recommendation. We have to check the balloon crossability. If not, we try to do the microcatheter crossing, and if it cross, we can use the rotablator or orbiter by after changing the wire. And if it is not, laser might be the best way to ablation, right? And then optimal balloon expansion, and sometimes we have to use a shock wave, and then we could get a good stent implantation. If the score balloon cross, you can use an imaging, and then you can make a score and follow. I already explained you, right? And finally, you can make a crack and put a stent. I personally do have not much shock wave, because at the moment in Japan, it is not available. We are now trying to do the study to permission, right? So the final problem is a calcified nodule. At the moment, I do not have enough recommendation, but compared with non-calcified nodule, calcified nodule might be the worst prognosis, even in a calcified plaque, and laser ablation might be the best way, I speculate at the moment. This is my take-home message to the my friend in Asia, right? In case with heavily calcified lesion, rotational atherectomy with small bar size would be recommended. If any imaging device, it could not be passed through the tight lesion, OCT may allow us to demonstrate clearly the position, distribution, and thickness of calcium, although IVUS might be more sensitive to detect the calcium than OCT, because IVUS can get a deeper image, right? Lesion modification and site and degree of ablation can be clearly observed after rotablator and orbital atherectomy by intracoronary imaging. Step-by-step change in bar size and rotational speed would be recommended for ablating calcium safely using wire bias. A calcium plate fracture can be made by high pressure ballooning with non-compliant scoring or cutting balloon. If the thickness of it becomes less than 500 micron, enough stent expansion and less instant restenosis could be expected if calcium plate fracture can be obtained after high pressure ballooning following step-by-step calcium ablation by atherectomy. Okay, thank you very much for your kind attention. I will be the Congress Chair of APSC 2022 in Kobe, so please join us. Thank you.
Thanks, Prof. Thanks a lot for the very concise and simple messages. I'd like to just now go and take a few discussive points. First, I would like to ask Dr. Sengo, actually, is there any type of patients, subset or characteristics that you would not consider using OCT as an imaging modality?
Thank you, Jack, and thank you, Professor, for the excellent lecture. So in my practice, of course, the challenges with OCT are one, if the patient has elevated renal parameters, the contrast is an issue. Sometimes we tend to not to use OCT. And sometimes even in a very tortuous lesion, very tortuous calcified lesions, we find the OCT catheter unable to cross. So in such situations, we tend to use either IVUS or just go without an imaging, the more common situations.
So the most common is what you say, the renal impairment, tortuosity, as well as maybe some of the osteo lesions. Sometimes it's a bit challenging for OCT imaging. Can I also now come to Donnie, actually? The anatomy consideration, does it really sway you between OCT and IVUS? When do you tend to favor IVUS over OCT?
Well, at the anatomic consideration, I think is we found a very big anatomy of coronaries, especially for the left main. Sometimes we have 5 or 6 mm in diameter. So I think IVUS will be better. That's the anatomic consideration.
Thanks, Donnie. So very large vessels. Alan, before we hop onto your talk, do you have any other points to add? When would OCT outperform IVUS?
So for those critical type lesions, sometimes even we cross the OCT catheters, you cannot get a good image. So so for those critical type, so either you pre-dilate it with a small balloon before you pass the imaging catheters, or you may need to switch to IVUS. Of course, there's some advanced techniques like push and pull. So you just inject, flush the lumens away with the contrast to clear up the blood and then push the catheter. There's a little bit more advanced techniques. Those you need to master it. The timing is important, but most of the time, in case we can't really get a good image for those occlusive lesions, you may need to use other modalities.
So very, very tight subocclusive, occlusive, without being able to pre-dilate, the dye cannot get across, you can't get a OCT imager. So we heard a lot of limitations, actually. I'd like to hear when you would do OCT over IVUS. Anuruck, when do you think actually OCT is then superior?
Just only I want to see the things behind the lumens. I think if you have some ambiguous lesions like the calcified nodule, calcium protrusion or something like that, I think OCT will give more information because we can choose the adjunctive device more specifically. That is my answer.
So Anuruck made a good point in terms of resolution, clarity. If you can get a good image, OCT definitely has higher resolution and clarity to define the lesion. If you can get past it, particularly for tortuous lesion, not so great for osteo, not so great for extremely large vessels. I have a question to Prof. Akasaka.
Yes, please.
You showed a case where you pass a 1.5 rotablator, you had some single plane crack, and then on a follow-up OCT, you said this is the image I need to put in a 2.0 burr, because a 2.0 burr means that you must have pre-planned a larger guide, you see, and none of us put in an A-French guide up front. So can you share with us what are the OCT parameters before you use it to upsize? For example, you already had a crack. And when you test with balloon first, or you go up front with a larger burr?
Yeah, it's depend on a case, right? Yeah, if it is very tight and any kind of modality could not pass, and if I think the balloon should be enough, we try to do the balloon, but even the balloon could not pass, we do not have any way to make an treatment, right? Therefore, at that time, we tried to use a rotablator, but the bar size and the final result might be difficult to expect or predict, I mean, right? So we try to change the system, from 7 to 8 or something, yes. But we speculate only by fluoro CT or other modality. It might be useful to do the 2 millimeter per ablation. We try to use an 8 French guiding system from the first. It's depend on a case, right? So sometimes succeed, sometimes we have to change the system from the result. Yes.
Thanks, Prof. Last comment from Eng Han. You heard Prof. Akasaka present a few algorithms. Do you think those algorithms works for you? Or do you have any comments to those algorithms?
Well, I think I think Prof. Akasaka's algorithms are the ones that we commonly use. If we so basically for me, right, I would tend to choose OCT over IVUS if the lesion is highly calcified, because the OCT resolution is much better than IVUS for that, for calcified lesions. And also for very calcified lesions, a lot of times it's the post-stent optimization that I see the benefit for using the OCT, because the stent, once the stent is deployed, if there's extensive calcification, a lot of times I'm worried about malapposition, which can easily be appreciated on the high resolution OCT images compared to IVUS images. And of course, there are guidelines to how much acute stent malapposition is acceptable before the stent thrombosis. But from practical experience, it is not possible to have no malapposition in very diffuse calcification. So yes, if I look at the algorithm that Prof. Akasaka presented, these are it is very useful, step-by-step guide. And I think if we follow the algorithm, a lot of times lesion preparation is the most important. We use IVUS or OCT to address the lesion, look for areas to debulk. This actually decreases the chances of complications. A lot of times the complications may present as perforations because of the calcified nodule, perforation, big dissections. All these have impact on the final outcome of the case.
Thanks, Eng Han. That's a very, very good points. So we're going to use now switch to OB-Van. Can you show us Cam 1, please? So we're going to switch to the cath lab and maybe use a case and then a live case to illustrate some of the points brought up before we go to the second lecture. OB-Van, are you ready to show Cam 1, please? So we're live with you, Jiaming. Are you able to hear us?
Yes, good afternoon, Jack, and everyone of the panel. Welcome to the lab. So this afternoon we have elderly gentleman.
So Jiaming, I just actually asked you to say hello. I'm going to now share the PowerPoint. So our cath lab today, we have Dr. Pham, Dr. Idu, as well as Dr. Chin helping with the OCT narration. So Dr. Chin is on the right side, all ready to go to tell us more about the OCT images. So I'm going to quickly just share the case so that Dr. Idu can present. Just give me a minute.
Okay, so patient
so Idu, you can see the case, huh?
Yes.
Okay,
so
so
patient
go ahead,
is an 87-year-old male. He has risk factors of hypertension and dyslipidemia. He's a non-smoker. Also has gout. Next slide. He's got a previous history of PCI over 10 years ago. No records on our electronic system. And he presented early in May with NSTEMI, chest pain, and cardiac enzymes. And coronary angiography then showed triple vessel disease. 2D echo showed normal EF of 63%. He declined CABG. and preferred PCI, and we actually did a PCI to the right side. 2 stents were put in, 3033 and 3533. And these are his labs. The labs are essentially normal HB and normal renal function. Lipids are well controlled with statins. Next slide. Now we go through the angiography of the left coronaries. Okay, so there's a diffuse LED disease. Next slide. So this is iliacaudal and ariocaudal views. Next slide. Okay, so the right was what was done the last time, stented from proximal to all the way to the distal RCA. Next. So in summary, we have an 87-year-old man, hypertension, dyslipidemia, triple vessel disease, RCA stented, now for PCI to the left coronary system, and our target lesion is actually the LAD. Now, thank you.
Thanks a lot. I'm just going to take a quick pause here to let the panel have a look at the images. So the target today is a long diffuse LD lesion, large diagonal. The right has been tackled. It's an 87-year-old gentleman, normal renal function, normal EF, but long diffuse disease. So maybe I can just quickly ask Anuruck, is this someone that you consider imaging for, and would you actually still do OCT for this case?
Sure, because I think OCT will give us a lot of information about the landing zone. Because it's a diffuse disease, it's very difficult to find the normal tissue around this area. And the second thing is it's quite the calcification lesion. So I love to see the OCT to do the stent pre-planning and optimization. The problem is these tortuous and heavy calcifying may cause the catheter, OCT catheter cannot pass because it's poor support due to the short monorail system. Maybe we have to do something first and check after, do the LOTA or do the orbital atherectomy and see what's happened next.
So can I ask Alan, would this be lesions that you pre-dilate before you pass the OCT catheter, or you think this is okay? Can you give us some pointers?
Yeah, I think from the angiogram, I think the OCT catheter is able to cross, but the issue is a very big LAD territory. So in order to get a good image, just say take a guide shot may not be get a good image. So of course, we really go ahead for OCT image. Sometimes in our scenario, we may, for example, take a guide extensions to deep sit into proximal LAD and get a better shot. Of course, it takes extra cost and risk. So because you also have a huge left surf territory, so in case you just take the guiding shot, so most of the contrast will distribute to, for example, diagonal, the circumflex, and the fairly distal LAD. But I'm pretty sure the latest OCT catheters can able to cross these lesions, right? Should not be a big problem.
So thanks, Alan. So OB-Van, can we go back to the cath lab again? And then we'll have Dr. Pham tell us his strategy for the case and tell us what we've done so far. So Pham,
thanks,
we're back
Jack.
at you. Yeah.
Can you all hear me now?
Yeah, clearly. Please go ahead.
Yeah. So maybe can we show the angio pictures?
Yeah. Now we're seeing the radio side.
Yeah, the patient is has a tortuous anatomy, so we did a radial shot first. And just wanted to show you how tortuous the brachial cephalic artery is. So I had to use a hydrophilic wire to pass my catheter down. Yeah. And after that, we first take a diagnostic shot of the right, showing that the stents are patent. And we elected to use the radial approach, given the fact that he's elderly, right? We were considering going through the femoral approach for better support. By the end, we thought that we can still go through the radial approach because he's elderly. So this is the first few pictures. This is an EBU 35 guide.
So we have a bit of a lag. So I think we're still seeing the RCA. Now you see the lag. Yep, go ahead.
Ah, okay, okay. Yeah.
We are waiting for the images to play actually. So there's a bit of a lag there.
There's a bit of a lag. Eh?
Yeah, so I think OB-Van is going to rebroadcast the pictures. Just give them a while. So tell us your thoughts, Jiaming. You're thinking that you're going to, do you need to pre-dilate the LED?
Well, actually, I was hoping to pass the, to test whether I can pass the OCT down the LED. So actually, so these are the pictures. Are you all seeing the pictures now?
No, sorry. I think it's still jammed up actually. So we
okay.
see that it's freeze frame. So we give OB-Van a while. Maybe you can speak to us in the meantime. So what you're planning to do is that you pass the OCT primary without pre-dilatation. Is that what you're saying?
Yeah, to see whether we could pass it down. Yeah. And then we also want to treat the diagonal as well. So for the diagonal, actually, I elected to pre-dilate first before passing the OCT down the diagonal. Yeah.
Yep. Okay, good.
Yeah.
And then do you OCT the diagonal as well?
Yes, yes. We wanted to show how we can deliver the OCT down both the LED and the diagonal. So can the OB-Van show the pictures?
So we'll try to go back to the OB-Van. If we can't, then maybe OB-Van can try to show us the OCT first because the focus is really on the OCT today. So, okay, we are back at you, but it's a bit laggy. We see probably looks like a lateral plane. Okay, so Jiaming, I think it's not optimal because it's a bit laggy. So we're going to give OB-Van a while to sort out the bandwidth. I'm going to just stop share here and ask Anuruck to share with us the second lecture, which is the MLD algorithm. And you take your time to just store your process. Then we'll come back to you shortly.
Okay.
Okay. Yeah.
Will do.
Thanks. Sorry about that.
Thank you.
So we're going to stop share here and ask Dr. Anuruck to lead us through the MLD algorithm.
Sure. So my lecture today will be the OCT MLD SMAC algorithm treat the lesion right. I have no conflict of interest for this talk. The MLD, what does it mean? It means the short abbreviation of the word that MLD is for the pre-procedure planning and the MAX is for the stent optimization. It starts from the LILAB program that this is the way we recommend to do the OCT in the all lesions. So it will be better to show the case to do the case example to see what you want to do with the MLD SMAX. This case is a 22-year-old female with the LAD lesion, residual LAD lesions. It's not easy to cross that lesion, even though I tell our team that is a very easy lesion, but it takes time to cross the Y. And even though the microcatheter could not pass the lesion, we have to pass the bare lower Y down there, and it's stuck here. Very difficult to pass the lower Y downward, and we do the lower first, 1.25, because the distal part is very small. We do the H1 of the rota to successfully cross the lesion. With this kind of thing, it's small vessels, heavy calcified, and I think it will have the problem with the OCT catheter because it will got stuck and we cannot see because the blood stain in the distal part, but we also try to do the OCT. This is the first one of the OCT. The OCT show that distal part is the fibrous part. It has no dissection from the rotablator, and this is the lesion part. It has some dissection, but proximal of the lesion is have the circumferential superficial calcium. Some parts was abrasion, but it still have a thick calcium around there. This is the way that morphology tell us from the first M of the MLD max. M is mean morphology. You have to know the pathology behind the region. You have to make the decision after you see the pathology that you need the adjunctive device. For this lesion, after you do the rotameter, you can measurement the thickness of the calcium is still more than 500, and the length is more than 5 millimeters, because from 30 to 40 is 10 millimeters long. So from the longitudinal view, you can see the calcium is from along that part. And after that, you have to see the morphology, that which part is looks normal. So you can choose the proximal and distal reference. Before we pass to the morphology, this kind of lesion we call the fibrocalcific lesion, and describe it thick superficial circumferential calcium, and we also measurement the very important things. And in 2021, we have to mention this is a superficial calcium sheet, because another form of the calcium when we use the OCT is will be the nodular calcium like this in the B picture and the C picture. And sometimes it have the eruption of the calcified nodule. It look like the red thrombus from the picture. You have to see the other cross-sectional view to see that it have the calcium. If you see that, it might be the calcified nodule, not easy to dilate it. And with this kind of thing, with this kind of presentation, we will have the more information about natural history of the calcium, like this paper presented in 2021 by the Dr. Womani team. The hypothesis that the calcified lesion have the natural history. It starts from the fibrocalcific plaque, and it have the necrotic core with calcium. It look like the sheet of the calcium like this, but when it's bending all the time, the calcium was cracked and caused the calcified nodule and caused the thrombus and sudden death. All of this thing is the morphology part. The second thing is the length. The length, you have to measurement the length of this vessel. You have to see the luminogram first or the luminogram first. From this picture, you can see this is the largest part and this is the largest part from the proximal reference. So you can measure the length of the segment that you want to use. And don't forget that the length that you choose, you have to check the tissue characteristic. That is the most normal tissue. That is the length of the vessel. And in this case, because it's crossed over the first diagonal, which is the big vessel, so you have to prepare 6 to 8 millimeters for the pot algorithm of this. So the diameter you have to choose two things, because from the OCT you have to lumen diameter and the external elastic lamina or EL for the diameter. In this reference vessel, distal reference vessel, you can see that for the lumen diameter is just very small. It's just 1.3, and the EL is 2 millimeters. So it's too small. It's too small and may be very easily cause the dissection from your stent. And the proximal part is quite big. If you choose the EL, it's a range from 3.4 to 3.8. It's quite a big one, but the lumen is big enough because you can see the maximum diameter of the lumen is 2.75. So if you want to choose the safe stent to put in, you have to choose between 2.1 to 2.75 or 3. That will be more safe in this case. And don't choose the stent bigger than 3.5. It will be easily to cause the dissection. So we already conclude the MLD. So we have to have three options. First, we have the two stents with 2.25 and 3.5 by 18 to cover the 33 millimeter long. Or second option is 2.25, 33, and do the pot with the 3.25 at proximal before the bifurcation, because we can choose this because the 2.25 from the stent design, they can cover 3.5. Like the sign, they can over expansion to the 4.4, and we should not choose the promos element or the intricity because it have or the taxes because it have the limitation of the expansion. But at that time, I'm not concerned about the port much, so I choose the shorter stent and 2.25 and post-dilatation with the 2.75 balloon. And before you pass this algorithm, you can see that it's very less dissection. So we have to see the calcium fracture before putting the stent. So this is the picture of the calcium fracture. So I do the pre-dilatation with the scoring balloon 2.25. By adjust the pressure, the low pressure is at the distal, the mid part is more higher, and the very high or ultra high pressure for like 20 millimeters for the proximal part. So after you do the scoring balloon, you can see that you create the huge dissection and cause the calcium fracture. So this kind of picture, you can guarantee that you have the good stent expansion. So I put the stent 2.25, 23 and put inflate at the low pressure and do the post-dilatation with 2.75 balloon, and with the increase the pressure. And for the max, the optimization, you can see everything in one shot like this, because the max is mean the medial dissection, apposition, and expansion. Let's begin with the medial dissection. You can see from the first start of the stent, this is the first start of the stent, you can see that the intima is intact. So it means that there is no dissection at the distal part, and you can go to the proximal of the stent, and you can see this is the last start of the proximal stent, and also no dissection here. So you first have the first optimization, the medial dissection. This picture is no medial dissection. The second thing is the apposition. You can see the white bar here. The white bar here is represent the malapposition. If you have the malapposition between 200 and 300, it will show yellow picture, yellow color, and more than 300, it will be the red one. And this is the white all. That means all the stent is apposition. And the last thing is the stent expansion. This show the tapering method is show that is the stent expansion is 100%. So the stent optimization for this case is nice. Another thing to play around is when you see, it's 10 minutes now, so I have to wrap up. When you see the apposition, you can rotate and see the red color is just a small area, not a long lesion. So for conclusion of the max medial dissection, if you have the medial dissection more than 90 degrees and injury to the media, followed by the intramural hematoma or foramen, you have to do the stenting. If you have the apposition, you have to malposition more than 300 micron and longer than 3 millimeters, you have to do the post-dilatation with the compliance balloon 1:1 in a nominal pressure. If you have an under stent expansion, like it's less than 80%, you have to collect with the NC balloon high pressure. So this is the final angiogram of this case. I think it's nice. So thank you very much for your attention.
Thanks. You want to just finish up your summary? Maybe you summarize.
I think it's the same. It's okay. We can discuss. It's better.
Thanks, Anuruck. That was fantastic. Thanks for keeping to the 10 minutes and timing yourself. Really appreciate it. I just like to ask, this MLD max, one is pre, one is post. Sounds very simple. It looks fantastic. Can I ask, what do you think is missing from the MLD max that is usually what you practice? Dr. Sengkang,
yeah, thanks, Jack. The whole idea of MLD max is to simplify the OCT interpretation and make it easier for experienced operators as well as the beginners. So there are many other aspects which we can look at it, but I think this is the most important things what we focused on. The other things, particularly what we were earlier looking at, is whether there is any protrusion through the stent struts, whether there is compromise in the lumen, whether other than that, whether the stent we can look at in many other areas like stent thrombosis. We can look at other pathologies. I could think of. Yeah, I think these are the most important things. Though we can look at many things, I think we are only focusing on these 6 things, Jack.
Okay, so it makes it simple. And any other comments about what is good, what is bad about the MLD?
Because see, the importance of pre-procedure imaging is given, because most of the studies have shown the pre-procedure imaging is more important than the post-procedure optimization, where we get up to 83% in the Light Lab study. They've shown the benefits of pre-procedure imaging. So the importance of both pre and post is given in this, and now with the newer algorithms and newer integration with the AI, artificial intelligence, they are going to have automation, and the time of MLD max estimation is going to be shorter, which will essentially turn into a very short time, or even a very, very less time for the operator, even for a beginner to take up this imaging modality.
Yeah, we're looking forward to that as well, assisted. They might as well do the case for us. But can I ask Alan, the point that Anuruck brought up, when do you use the MAX algorithm to choose a compliant versus non-compliant balloon? Can you emphasize that point again in terms of the apposition as well as expansion?
Yes, I think for most of my practice, may not be for rest of the practice. So I use lots of non-compliant balloon, even for the pre-dilatation. So it's just avoiding lots of extensive, oversizing from the semi-compliant balloon to get more dissections beyond your target segments, right? To avoid extending your lesions, and of course, to avoid geographic miss. So I think what is missing from my point of view is it didn't really signify the endpoint before you put in a stent, right? So I think if you are going more advanced, just like for challenging calcified lesions, so we need to go into more algorithm within the algorithm, just like the OCT points you have from the Akasaka's talk, right? So you are frequently using the Fujino's scoring. 3 points, 4 points, and then what is really missing is what is the threshold before you put in stent. So I think this is we need a good calcium fracturing and also a good lesion preparation for most calcified lesions. And I think for the rest of the lesion, like fibrous lesions, most of the time if you brought the lesion well, you can see dissections and then you can put in stent. So also you need to properly re-imaging of the target segments after you have the lesion preparation. Sometimes you may have extensive, for example, edge may not necessarily the same segment. You may need a longer stent, so to fully cover the dissection you've induced. So, and one more important point I want to highlight, I think from the case share is a wonderful job, but most of the time for occlusive lesions, you need to give a lot of nitrates to dilate the vessels. I think for the first OCT, it's still constrict. It's not fully dilated. So that's why after you blow up the it's a 2.5 stent, so it looks nice. But probably before from the beginning, the OCT just showed the vessel is still shrinking. It's not really dilated up. You need a lot of
yeah. Very, very strong points. Maybe this group will propose a MLD pause max, where you assess what is your MLD assess and lesion prep before you go on to the max. So you don't want to put in a stent before that. So Prof. Akasaka, maybe last comment from you. Do you agree with the sequencing between apposition, try to use a compliant balloon, and expansion, try to use a non-compliant, or it depends on the calcification, like what Alan was talking about?
Yeah, basically I agree Alan's comment, but it's depend on the calcium thickness and the distribution, right? Yeah, it is very important to identify the position of the calcium and thickness of the calcium, and at the same time we have to check the opposite side of the calcium. If the opposite side is completely normal, and if you try to apply the MLD max, we expect to expand more than 90%. But at that time, there are some risk of perforation. So it is very important to check the calcium thickness and the distribution. Yeah.
So we hope to go back to the lab to maybe have some pointers, because there are some questions from the audience to ask about if it's a large vessel nodular calcium, what adjunct device, what is the optimal result. I think all these questions you need to individualize to the case. So we're going to go back to the lab to hopefully look at some live OCT images, maybe have the panel comment. So OP-Van, can you switch back to the case? I've asked the lab to just proceed to continue doing the case.
18, 20,
And while they're doing the case, I'm going to ask Chi Yang instead to narrate. So yes, sorry if Dr. Pham, we left you be for a while. I know I asked you to just go ahead and stand the LED. Well, I'm going to just take a pause here while you're still doing a case. I'm just going to switch over to look specifically at the OCT that you've done pre-procedure. So Dr. Chin, are you able to share with us the pre-OCT and then narrate to it and share with us what your findings are?
Yep, sure. You can hear me, I presume.
Yep, we can hear you. Go ahead.
Okay, so this is that you're seeing here is the OCT pullback of the LAD pre-PCI. The pullback starts at somewhere where my cursor is pointing at. We have the angio registration here in the top left-hand corner, the OCT cross-sectional view here, and then the longitudinal views at the bottom of the screen. So one of the things that Professor Akasaka always teaches, and I've always remembered, is to, if you're imaging from the LAD, to try and position the circumflex on the 9 o'clock position. So you can do that under settings, and you can rotate your image. So if you position your circumflex at the 9 o'clock position, it helps you orientate yourself to the vessel a little bit better. So at this position, you know that on top is the epicardial surface, and down here is the myocardial surface that can help you determine where your plaque is distributed. So anyway, so we see two wires, one is in the diagonal and one is in the LAD. So going proximally, we see the presence of an old stent. You can see the stent struts behind a layer of tissue. It's mostly, I guess, fibrous kind of tissue. So looks more like just neointimal hyperplasia. Not sure if that's a hint of some neoatherosclerosis going on, but mainly just neointimal hyperplasia within the previously stented segment in the proximal LAD. So here's the diagonal, and the wire disappears into the diagonal. And now we are left with one wire in the LAD. And as you can see, the white marker here in the angio-reg, that tells us where we are looking at. And here is roundabout where the lesion begins. So we can see some calcification here at the 7 o'clock position. As we go further down, we see more bits of calcium here and there. So calcium on OCT has already been shown as a low intensity signal with well demarcated edges. So going more distally here, you see the again mostly eccentric calcification, but it goes more than 180 degrees around the vessel. Here the lumen is quite tight. A lot of what looks more like lipidic flap here now. So there's low intensity signal, but not well defined, not well demarcated, and with signal loss. Again, going more distally, appearance of calcium again. Again, mostly eccentric and mostly on the inferior border. So this is the myocardial side of the artery. And another tight spot down here. And then this is probably as normal as we can get in order to land our distal edge. So to further assess the degree of calcification, of course, we all know about the OCT calcium scoring system. So one of it is maximum calcium thickness. So here, calcium thickness is 0.97. So that's more than the 0.5 millimeter cutoff. There are other areas where the calcium thickness is also quite significant. It's about 1 millimeter there. So it already scores 2 points there. In terms of length, obviously, this is definitely going to be more than 5 millimeters. So it scores another 2 points. And we already saw that in terms of the degree or the arc, it's more than 180 degrees in some spots. So that's another point. So on the OCT, by the OCT scoring system, it is all 4 points. But I guess I must add that, you know, I've seen a lot worse calcification. Sometimes, you know, you get a lot of very thick calcium, concentric all around the vessel. So although the score here is 4, it's mostly eccentric. Not a lot of it is disjointed. So there's a big chunk here, a big chunk there. So I think based on this, hopefully balloon dilatation alone, high pressure, should be quite effective. But I'll leave the other panelists to comment on that.
Thanks, Chi Yang. That was a wonderful narration and demonstration of a beautiful OCT image with co-registration. Enghan, can I ask whether Chiang told you enough information based on the MLD algorithm for you to decide where and what to do? Go ahead.
So I agree that the OCT pullback gave a lot of information for pre-PCI planning. Now, first, when I deal with a diffusely calcified vessel like this, the first thing I would think about would be guide support so that I can deploy equipment down the vessel. And the guide support chosen for this case was EBU 3.5, which I think is sufficient. It's a 6-branch system. I don't think we need anything more than a 6-branch at this moment. So the fact that we can actually pass the OCT catheter down predicts that probably we'll have no problem passing down balloons later on, and whether we can pass stents down depends on how we prepare the lesion. I did not see any nodular calcium. There's definitely high plaque burden and high degree of calcification across the vessel, but I didn't see any part where it is napkin ring type of calcium or 360-degree calcium. The vessel itself at the tightest portion where around here, where there's a lot of calcium, where there's a lot of thick calcium, the IVUS catheter tends to be biased towards the calcium. So for me, I think, even though I agree that perhaps balloon dilatation might be sufficient, for me, I prefer to do some form of debulking or plaque modification. My choice would be a 1.5 rotor burr, which would fit into the guide and do another IVUS pullback after doing the rotor ablation and balloon dilatation, and determine the stent size after that. That is how I would approach this case.
Thanks, Enghan. So, Donnie, would you agree, Enghan, that based on this high scoring points that the OCT catheter can pass, would atherectomy be your first choice?
Yeah, I think, Jack, because the scoring look like it's definitely more than 3, right? I think it's 4. And then I noticed there's some heavy calcification in some point, the tightest one. And I doubt that the balloon can crack that. So my choice in this kind of situation, I prefer to do whether rotablator or orbital in this kind of situation and bring down the OCT after the imaging, and then see what's happened there.
Thanks. Any other points of view? Anyone? Before we hear from Dr. Pham what he wants to do.
Is there a good landing zone because of the distal landing zone? Okay, here it looks good. Okay.
So, Chiang, you think the landing zone here is good? Where the co-registration shows
there's no normal vessel. It's all diffusely diseased. So, you know, this is probably as good as we can get somewhere around here. Still a lot of plaque, so we have to be very careful when we implant the stent not to go too high pressure or oversize the stent. But there's no other good area to land the stent. So we have to make do with what's the best or what's the least bad, I guess.
Chiang, maybe you can share with us in the MLD algorithm, how do you point out the length of the lesion as well as the diameter? How would you advise on sizing and stenting sizes at the end?
Yep. Okay. So with OCT, there's a lot of a lot of things are automated, so it's very easy for the operator. So if we look at this bar over here, you can pull the margins, so you can adjust the margins to according to where you plan to or where you think is going to be your landing zone. So this is the distal part, and this is the proximal part. So you can adjust that. And once you've placed the markers where you want to place your stent, this a number automatically comes up. This is 34.6 millimeters. So immediately you know that the length is going to be about 34.6 millimeters between the two landing zones. For diameter sizing, if you can see the external elastic lamina, EEM, then ideally you should try and use that. So in this case, we can probably kind of just about make it out over there. So if we go from EEM to EEM, that's going to be about 2.8 millimeters. If you go on the long view, you'll probably be guessing maybe about somewhere around here. So you can take an average of those two. So that's the distal diameter. If you cannot see the EEM, then you just have to make do and use the lumen. So if you use the lumen diameter, you would, for example, let's say your lumen diameter is 1.7, you would size your stent a little bit bigger than that, so maybe a half size bigger. If you are able to see the EEM, then you size it down. So usually we, unless there's a lot of tapering, usually we use the distal as the reference because it's smaller. You can also check the proximal diameter, obviously. In this case, proximal. Again, you can't really make it out. Yeah.
Anuruck's point is that you just be careful about having too much of a discrepancy. But it was very nice narrated. Can I ask Alan then, what is your preference? Do you always look at EL to EL, or is it always sometimes it's so bad you just look at lumen?
Yes, I think this should be the most difficult, or I mean for the beginners using OCT to size the vessels. I think basically the MLD max are mostly based on the lumen criteria in using OCT to guide the PCI. So the key is that you need to find identify the both proximal and distal segments, right? So in identifying the distal segments is for us to judge the stent size. So I think for challenging case, for diffuse disease, sometimes it may be very difficult for us to get the right spot. I think in this case, it's part of the reason and part of the one of the case that you can't really get a really decent landing spot. So we try to avoid land into moderate disease because these studies show us this predict edge restenosis. Also try to avoid some calcified plaque, so because it makes it difficult to dissect, and then we need to make the scenario difficult. So I think he already make a good spot, I think. But if you're counting the EEL measurements, right? Usually we need to get a regional assessment of the underlying EEL at least more than 180 degrees. And for this, I think you need to use your judgment. You measure the EEL diameters, and then also measure the luminal diameter to judge and then to get the estimate, right? For example, in this case, I think for the EEL probably 3.0, I think I will never put in a 3.0 stent here. And from the luminal diameter probably is 2 something like that, and then is need to upsize from the luminal and downsize from EEL. So overall, I think for this challenging scenario, not a typical one, you need to use together this information you can get. I think you need to also incorporate your judgment to get a, for example, aspect in between somewhere, probably together with the angiogram, 2.5 distal stent. I mean, 2.5 size for distal stent may be a reasonable options. And then you get length. And then for the proximal, usually for this diffuse disease, I will use the luminal diameter to blow up my, to optimize the proximal region segment.
Thanks, Alan. So I think this point is worth re-emphasizing because I find it's the most difficult for beginners, like you said. Although you see everything so clearly, you're still guessing. So maybe I'd like to ask Anuruck to make whether there's any teaching points before Sengo to add on to this. How do you? So Anuruck first, then Sengo.
Okay. For me, I think when you choose the lumen diameter for the stent, it will be very safe. And when you use the EL for the stent size, it will be get the good expansion, good luminal area. So both of them have the limitation. For the small vessel, you have the under expansion. For the undersized stent, you have the under expansion. You have the not the good long-term result. For the MLD EL, you have the bigger area, so you will get the better result, but you have the poor immediate result because it have a high chance of dissection. So when I use the diameter for the D from the MLDs, you have to set up in your mind that this is the minimal that I can accept, and this is the largest one that can I accept, and do do the balloon post dilatation to adjust because the stent can overexpand it, because the stent design can design from the 2.25 to 3.5 in the small size of the stent, and for the bigger size, it start from 3.5 to 5.5. So you can adjust it with the balloon after you put the stent inside. But you have to remember the diameter from the pathology is the limitation. Extreme side dissection, the less the lumen, the small size will be poor lumen area. This will be cause the long-term result too.
Thanks, Anuruck. Sengkang?
Yeah, sometimes in diffuse disease, you have the entire vessel is diseased. You will not be able to see the EEL at all. And then you have to go by the lumen diameter. And very often when the part of the Illumin 4 trial, we were always advised to check the EEL and downsize it by quite a size. And if you're not able to see the EEL, then only you go to the lumen diameter. So, but then upsize it. Very often, if you downsize from the EEL or upsize from the lumen diameter, there is a match of the stent size in majority of the cases.
Thanks, Sengkang. Good point. I would like to ask our master, Prof. Akasaka.
Yes.
Do you downsize from EL or upsize from lumen?
Yeah, we always use in the both, right? It's a little bit complex to the beginner, right? But if you try to use in the lumen diameter, we always use in the quarter size bigger. And if we decide by the EEL, we always downsize the quarter, right? So it depends. But in this case, the mean lumen diameter in the distal portion is 1.89. Therefore, more than 2. So 2.25 is the ideal to avoid the distal dissection if we put a stent. And proximal is the diameter is 2.5. Therefore, we will select 2.75 there. So it might be better to use in the 2.5 if you use in the one stent in this case. And we can get a good result after putting a stent by using the balloon dilatation. Then select the 2.5 and put very gently with very low pressure to protect the distal the damage, and then try to dilate in the proximal site. It is the best way in this case. It's depend on your experience. But yeah, for the beginner, if you select the safety, it is important to select the small size, right?
So
I have a question.
Yeah, Donnie, please.
Yes, yeah, Prof. Akasaka, when I did this kind of lesion, long lesion calcification, and I did for very careful not to dissect and then doing just a lumen diameter, not forced to the EL to EL. But most of the time, I cannot achieve good IFR. So it's really difficult to get a good IFR post. More than 0.95 is almost impossible. So so what do you think? Most of the time, I would just post dilate almost EL to EL all the time. So what do you think?
Yeah, it is very important, I think. But IFR, if the IFR is enough high, we can believe. But in this case, we have to expect some distal embolization. At that time, some hyperemia may occur, and the IFR may low, or it's depend on the case. But so if the IFR is low, we have to, we cannot believe the value, right? We have to do the FFR at that time. Therefore, yeah, IFR is very convenient, I agree, but some tricks. Yeah, so we have to pay attention to the number.
I think, Donnie, for long diffuse lesion, it's very difficult to get a normal IFR post.
That's what I'm saying.
I think it's almost impossible, no matter what you see on OCT. So I'm going to go back. Obi-Van, can you unmute the cath lab? I want to see ultimately what Chi-Yang advised and what Dr. Pham has decided to do based on all the discussion on the imaging here. So Obi-Van, can you, Chi-Yang first, maybe you'd like to tell us what is your recommendation based on what you found?
Okay. Yeah, so as I mentioned earlier, although the OCT score is high, pattern of, I mean, this is not objective at all, but just the way the calcium distributed, it's not so concentric. I personally, if it were me doing the case, I would try with a high pressure balloon first. And if that achieved good expansion, then I would accept that. But we can see what Jianming ultimately did.
Yeah. So maybe you can flip back to view 1, and let's see Jianming and Angel. And Jianming, if you can, maybe you can take a pause and let us know what ultimately do you do.
Yeah, thanks, Jack. Can you all see the angio clips now?
Yeah, now it's quite smooth. Go ahead.
Yeah, so just a recap of the baseline angios. So just bearing in mind the LEO cranial views, it's a very long diagonal and a long LED. I use this as a reference for my wiring. It's necessary to wire all the way down to the distal diagonal and the LED because there's quite a distance between the distal end of the OCT transducer and the imaging end. Yeah. So this is the REO cranial view. So I'm going to show actually how far down I actually wire down the diagonal and the LED.
Yep, so we see 2 wires, one in the distal LED, one
yeah,
in
so you can see how far down I have to go using the LEO cranial views. All right. Next, this is the intracoronary nitro shot that I always administer before I pass the catheter down to reduce the risk of spasm, vasospasm. This is actually the shot to show that I deliver down the OCT without pre-dilatation of the LED. So it's highly deliverable. Now for the diagonal, I have to actually pre-dilate it. So this was a 2O balloon. Next, can you all see how I deliver the OCT down the diagonal? It's actually quite tortuous.
Yeah.
Yeah.
Oh, I thought it was a good idea to pre-dilate.
You can see that there's quite a fair amount of distance between the edge of the catheter and the imaging end, as marked by the dot. So that's why I have to go all the way down to the distal artery. But we managed to deliver it anyway. Yeah. And this is just the pullback of the diagonal. So we actually stented the diagonal. This was Zion Sarah 2523. Post-dilated with a 25 NC balloon and subsequently a 275. I'm skipping it a bit more. I'm just going to show you the post-dilatation. Yeah, so this is the part in which we post-dilated with a 275 NC in the diagonal stent. All right. And then lesion preparation to the LED. This was a 2O balloon. And the non-compliant 25 NC.
It's very nice that Chiang is also simultaneously showing and following up with you on the OCT runs. Trying. So, yeah, very good.
And then in the end, I decided to, there's some wasting. So I decided to use a scoring balloon, a 2.5 score flex to pre-dilate, especially the proximal LED where the septal branch is. And we actually did an OCT after that. So maybe I think Chiang can show what we found after we did a scoring balloon.
Yeah, okay. Just a second.
Dr. Pham and Dr. Chin, after you do this narration, I'm afraid I have to take a pause and go to the next 2 lectures, 1 lecture first at least, before coming back to you. So maybe Chiang can show us what was seen after pre-dilatation.
All right, okay, so this is the OCT pullback of the LED after balloon dilatation. So this is proximal going distal. So we can start to see some dissections already. So yeah, dissection goes both ways. So this dissection is mostly, it's mostly around the calcium rather than causing a crack through the calcium. Sometimes with balloon dilatation alone is what we see. We see the vessel tearing between and around the calcium rather than cracking the calcium. But nonetheless, this is more distal. But nonetheless, there is quite a lot of dissection. And I think on the angio, the balloon does inflate quite well, quite fully.
So maybe I'd like to ask Inhan, who advocated atherectomy. Is this okay, you think, based on fluoro and OCT pose?
Yes, based on the fluoro, it looks really good. At this point, I'm quite confident that we should be able to put in stents. Based on the OCT, I'm just looking at the dissections and trying to figure out whether the dissection actually went through the media and, but these are deep, extensive dissections. I guess this is what we expect from balloon dilatation. It will,
so this is
Ellen? It will tear the vessel and not the calcium.
So Ellen, this is the pause moment that you say is a deficit of MLD max. So at this pause moment, you're good with this, Ellen, about whether we should do more?
I think it's highlight several of the important points I've mentioned. So in between OCT run, is give us a very good assessment of where you're going to further land your stent, because apparently I think the distal segments now move more distally, and for the distal segments, I think preparation is good. Only not really much concern, although it's a little bit from the fracturing. I mean, for the dissection inside the calcified segments, it seems it's commonly seen for this essential calcification when you blow up the balloon. Usually the dissection is in the junction between the fibers together with the calcified part, usually the region. And I think from this end OCT, I may pull up a bigger, for example, scoring balloon to further blow up those calcified segment further, and then to see can I get a bigger luminal gain before I put in the stent. But probably I think we don't need really a atherectomy. Of course, it depends on the availability of the device. Like, for example, if a 25 or 275 balloon still give a waste in those calcified segment, probably you may use short wave to treat the balloon. But of course, rotational orbital atherectomy is out because of nasty dissections. But for the rotational atherectomy, probably may not really have a great effect because the lumens already expand much. You cannot really abrade much, except you put a big burr, which is maybe too risky.
Thanks, Alan. I'm going to keep the audience in suspense and not show you what Dr. Pham's stent implant is like until later. I'm just going to take one question from the audience, which I find interesting, from Dr. Chen Tin Tan. Maybe Chiang can take this. You saw the OCT post Scoreflex. Is this level of dissection okay to consider a drug-coated balloon treatment rather than put stents?
I think there's more to that than just looking at the OCT. I think this is limit LED. It is a very important vessel. I personally would be a bit hesitant to leave it without
a stent. So a lot of hesitation there. Anyone would say that they are comfortable using DCB after seeing this result and this level of calcification? I see everyone shaking their head. So I think stents first. I think very few people will leave so much dissection and calcified pre-dilated lesions without a stent. So we're going to drop off now. So thanks a lot. We're going to come back to you. Please go ahead and finish up the case for us to show later. If we have time, we'll get Chiang to narrate some of the OCT posts as well for the max. So we're going to, in the interest of time, go to Alan to deliver his lecture. We saw a lot of questions from the audience asking when is atherectomy, what type more suitable. So hopefully in Alan's lecture, he can answer all those questions. Alan, please.
Okay, I can share my, okay. So thank you very much for inviting me to be part of this event. So it made me a very challenging task, a very challenging scenario, because just 10 minutes to cover this huge topic. I think we can talk this topic into more than 1 hour. So I will keep it simple. So so basically my 10 minutes will divide into 2 parts. Basically more case presentation. So first of all is orbital atherectomy. So I think most of you will aware of the basic setup. You have a pump, you have a electric console, you have the lubricant, as well as the wires, dedicated wire, rapid wires. And more important, you understand that this atherectomy device is based on this eccentrically mounted diamond-coated crown. In contrast to the rotational atherectomy, is the typical diamond-shaped crown. So what is this difference as compared to the rotational atherectomy? Is follow the physics of centrifugal force. So actually, the eccentric crown moves in orbit, just like this orbit. And in case you increase the speed, so the force will be greater, and as well the diameter will be bigger. So this is the first important information. So it's all come with a 125 crown. So one size should treat most of the vessels, ranging from 25 to 40 vessels. Unlike rotational atherectomies, for a 1.5 burr, most of the time you can only able to give up the 1.5 lumen, 2.0 burr, then you get 2.0 lumen. So for orbital atherectomy, actually it depends on the speed of the atherectomy. So if you're going to a low speed, high speed, you can actually increase the diameters or luminal gain. So very key important issue is orbital actually enables mostly constant blood flow and try to and most of the time is have less chance of distal lobe flow. Also enabled by directional treatments to allow, for example, forward ablation as well as backward ablations. So 2 important points as well. So the luminal gain depends on number of pass together with the speed of advancement. So most of the time we advocated a slow advancement of the burr, either advance or pullback, because if you have slow advancement and pullback, you can actually achieve a bigger luminal gain as compared to a more rapid advancement or pullback. As well, the number of pass also will increase the luminal gain as well. So if you have to do more abrasions, then probably you get more luminal gain. So tips and tricks. So always start at low speed, and high speed is usually for big vessel and more calcium sentings. So unlike rotational atherectomy, actually it's not a pectoral motion, which most of the time is quite jerky and high speed advancement. But you need to go very slow and allow adequate time of therapies. Most important, like rotational atherectomy, you can use your visual feedback, tactile feedback, as well as auditory feedback for adequate lesion preparations. So never stay at one single segment without moving, because in particular, if you are facing eccentric with fibrous tissues on the other side of the lesions, you may result in increased risk of dissection as well as perforations. So despite risk of no reflow as compared to rota, it still occurs, particularly to extreme calcified lesions. So it's supposed, we needed to say is, we encounter a lot of scenario, and it's supposed to be more effective in eccentric calcification and calcified nodules. Of course, it all depends on where is the bias dictated by the OCT. So never treated in-stent lesion with orbital because there is higher risk of stent entanglements. So the keyword, start low and go slow. So I will share this first case. So it's an eccentric calcification of the RCA in the severe AS patients, 80 years old lady. So we have first tried to treat the coronary first. So you can see the calcification is very eccentric in the inner curve. And at the beginning, we cannot cross with the OCT catheter. So we pull out our orbital atherectomy to try to avoid distal low reflow in these severe AS patients. But however, you can see I start with a low speed, but the catheter actually didn't really able easily cross, and it's a little bit stuck over there. And it's a more gentle advancement. You can see there's a sudden jerkiness of the catheters all the way forward. So it is time to check, and we have the thinking that this will be a problem. And in fact, because there's some dissection and some leakage over there. So, and this is the scenario of the eccentric calcification. Despite a low speed, and then if the bird just can't really go and keep on abrading a single segment. It will result in these kinds of dissection and perforations. So luckily, we were able to tackle this complication by simple balloon tamponade, and then the preparation gets sealed, and then we can put into overlapping stent. So in this case, we tried to using what we are trying to propose. So for this eccentric LED diffuse calcification, you can see actually the calcium wrap around the LED in spiral sections. So for more proximal segments, actually the calcium is more on the outer curve, whereas for the mid-LED segments, the calcium is more in the inner curve. So OCT, we get able to cross the lesion with OCT to better assess the lesions. You can see there's fairly diffuse calcification, some region with eccentric calcifications from proximal together to the distal. So we put up a orbital atherectomy for this case because of the eccentric calcification, knowing we need to be very cautious because we may introduce trouble like the first case. So for the low speed, we first of all, we try to open up the track to modify the both forward as well as backwards, and then treat the distal lesion as well. So you can see the bird actually go very slow. It's not like the rotational atherectomies maneuver. So it's a pectoral motion. It's not a pectoral motion. So after the slow speed, we go for the high speed because it's relatively big also from the OCT and the angiogram. But this time we only go for the advancing and maneuver for the proximal lesion because we aim at more wide bias toward the outer curve, the eccentric calcification over the outer curve, together with the pullback from the distal and mid-LED segments because of the eccentric calcification in the inner curve. So by incorporating this push and pull technique, so advancing the crown towards the outer curve while abrading the eccentric calcification, as well as pulling back the crown for the mid-LED inner curve calcification, we may able to use the wide bias and maneuvers, and then to try to have more specific lesion modifications. So this is the OCT pre, and after the optical atherectomy and after the balloon dilatation. You can see there is some calcium modification with this kind of snowman, some calcified burring together with this one. And after that, we used a balloon to blow up the lesions. You can see there's a lot of dissection as well as fracturing. So pretty sure I think we did able to achieve a reasonable luminal gain before I put in stent. And this is the final angiogram as well as OCT result. So this is what we incorporate the OCT in order to facilitate or to guide our complex calcified lesions PCI. So one more technical tips for aorto-osteal lesions. So we always try to avoid advancing the orbit from proximal to distal because of this unrestricted orbit in the ostium. You may risk of dissection the ostium, which we encounter. We observe this complication in many of the symposia. So what we is proposed is try to use the guide assist to pass the lesion down, the orbit down, and then try to use pullback techniques to have a more control of the ascending. So the rest of the talk will be rest on the shock wave. So I think it depends on your local availability. Shock wave is use the sonic pressure generated from the emitters through a balloon in order to achieve the calcium fracturing. Actually, it's dependent on the technology from the shockwave lithotripsy during with the kidney stone. So contracting essential calcium is a lot of huge topic, and I found this from their website, the shockwave website. And so for contracting calcification, usually is the most typical example which yield good results. So the reason behind is because of the calcium able to bounce back the sonic pressure within the lumen. So it's to get a more effective calcium fracture. Whereas for essential calcification, because of this fiber plug, the sonic pressure, the sonic pressure actually will travel outside of the vessel instead of bouncing back within the lumen. So actually, a lot of energy will be lost, and we will need extra therapy in order to achieve the same OCT result. So but this good size is it can achieve effective calcium fracturing. It's good at bifurcation because you can keep the side by device unlike the rest of the atherectomies. It's relatively simple to use. You can tackle both superficial and deep calcium, and suppose it's more useful for concentric calcification. And there's a lot of serious examples, case research. You can treat the stent under expansion secondary to underlying calcification because whereas it's not the previous operator didn't do a good job. However, the bad side is it's a bulky device. It's not effective in essential calcifications, and only there is a limited therapy per catheters, especially is a long diffuse lesions. So the technical tips and tricks is compatible with 6 French. We need to size our balloon in 1:1 balloon vessel ratios. There's only 8 cycles per catheters, and in each cycle we give 10 pulse of therapy. So that's totals 80 pulse. So inflate the balloon to 4 ATM and then deliver therapies up to 10 pulse per cycles, and then brought up to 6 ATM the normal pressure before you deflate. So but most of the time you're able to pass, but in extreme calcification case, you still need a reasonable lumen before the catheter can pass. So this classical example of LAD calcification is the bifurcation lesions. We're able to pass the OCT catheter. You can see there is a very concentric thick calcium along the LAD. So this is the 3O IVL balloon, the short wave balloon. So first of all, you can see the dot bone is good. And then after a repeat therapy at the same spot, you can beautifully see the balloon can yield, and then the balloon is opened up. So OCT shows there is beautiful calcium fracturing, and I think pretty sure we were able to achieve good stenting result after this short wave. And this is the stenting angiogram as well as OCT result. So finally, I want to share 1 to 2 cases in case allowed. So in super tight calcium, I mean this is super calcified lesions. Sometimes you may need combination approach. In this chip case, with a double CVO, impaired LV, EF, you can see a diffuse calcification along the LAD together with the CVO. So we use impeller to support the PCI during the LAD, cross the lesion with the XTRY, but no OCT catheters can able to cross. So just like the rest of the speakers have mentioned about before, we need to use upfront atherectomy. Just to follow the algorithm, if the OCT catheter cannot cross, you need to try to use a atherectomy device. And in this particular case, I used a rotational atherectomy to open up the tract. So OCT now come into place. You need to visualize what is the remaining enemies. Again, you can see there's a diffuse, thick, and concentric calcification, just like you have done nothing before. So of course, option here, we may try to use upside to bird, use 2O, or in my scenario, I use a shortwave leadership to further open up the lesion. 2.5 to get a 3O distally and proximally, and you can see beautifully calcium fracture. So there's no doubt I can guarantee the stent will expand. So we can see this beautifully stent expansion as well, reasonable appositions. The last case is a combination of orbital as well as lipotrophy. So it's an 80 years old gentleman, severe AS. Actually, it's a calcified man. You can see porcine aorta, severe AS, MAC, and triple vessel calcification. So this is a 3 vessel disease, and the first stage is treated to RCA. Again, severe AS, we don't want to blow up our rotational atherectomies. At the beginning, I can pass my OCT catheters. We can see there's a diffuse calcification as well as some essential calcification in the mid-RCA. We want to use a shortwave balloon to avoid atherectomy, but however, the shortwave didn't really cause advance much. And despite opening up the balloon a little bit, it didn't really able to yield a good result. So I tried to use orbital atherectomy this time because technically it's supposed to be less distal low referral. It's good for a severe AS case, and this is also the case for these patients. There's no ischemic change. After orbital atherectomy, you can see there's some lesion preparation in various regions, but still it's not enough. We use the same shortwave balloon, 3O, and then you still see a dot bone. After the therapy, you can see the balloon get you. And this is the OCT diagram showing pre and after orbital, and after the orbital shortwave. You can see beautifully the calcium fracture, and then they get much luminal gain. This is the final angiographic as well as OCT result. I think the OCT gives us a fairly reassuring result. Of course, you can still see a lot of this very deep calcium fracturing. We never know what is the long-term outcome, but without this calcium fracturing, we can always by no means we are able to open up the vessels. So, ladies and gentlemen, in conclusion, in echoes with the various speakers, importance of intracoronary imaging, in particular OCT, can help us to assess the significance of coronary calcification in high-risk PCI. The orbital atherectomy can allow good calcium modification and stenting, especially in eccentric lesions. Shortwave lipotrophy can allow calcium fracturing in particular concentric calcification. And it's important for all of us to need to understand and to visualize the calcium fracture before putting a stent. Otherwise, you will be regret. Cocktail or combination therapy sometimes may be need to treat these super calcified enemies. So thank you very much.
Thanks, Alan, for sharing with us some amazing cases as well. So in the interest of time, I'm actually going to go back to the cath lab. I do have a lot of questions for you, Alan, so don't run away. And we'll come back to you in a bit. We'll go back to the cath lab to let them show us what is the final result, the finishing OCT, before the last lecture by Dr. Lim.
Yeah, we're back.
Yep,
you want to show?
You're there, so we can see you, and maybe you'd like to tell us what you did ultimately. Jiaming, we're all eager to hear you.
Yeah, thanks, Jack. Are you able to see the angio clip now?
Yep, maybe you can play.
So this is the last time we left you. This is after the OCT run.
So you have 5 minutes to show us what you have.
Yeah,
Jiaming.
so this is to show you after the angio clip after the skull flexor. And we implanted with 2538 Zion Sarah.
So ultimately 25 stent, okay?
Yeah, 2538. I think this was the
position. So a few millimeters allowance based on what Chiang measured at 34. Yep.
Yeah, because there's some degree of dissection. We just want to make sure we cover the dissected segment. So we deploy.
There's actually no normal segment. Okay, go ahead.
This is after the stent. Post-dilated with a 275 NC and then a 30 NC at the proximal edge. Yeah. And I'll show you the result after the optimization.
Okay, stent segment now looks wonderful. Everywhere else looks sucky. But
yeah, so we did a final OCT run. So I'll just show you what we did finally. We further optimized with a 30 NC at high pressures at 24 atmosphere at the proximal edge. And these are the final pictures. Before I leave you with Chiang. Some lag.
It's a bit laggy.
Yeah, so this is the aerial view, showing the stent in the mid-LAD and a diagonal.
Okay, we're seeing that, the diagonal stent. The standard segment looks good, but the rest of the artery is very diffusely diseased. But I think for 87 years old, I think this is probably very good and adequate results, I would think. So congratulations, Dr. Pham. I think it's a nice result here, a good result. Can we switch to a full OCT view? Maybe you can share with us the MAX algorithm now on OCT post-intervention.
Okay, all right. So this is the post or the final, well, almost final OCT pullback. So moving from proximal to distal, this is the proximal edge. So we're looking for the edges. Obviously, we want to look for dissection. So that's the first M, right? So a tiny, really tiny bit of dissection there, which is negligible. This is the kind of dissection you wouldn't see on IVUS and definitely cannot see on angio. So that's okay. We go to the distal edge. Let's just go straight to the distal edge and look for dissections there. So dissections, if anything, would be more likely to occur in the distal edge because the distal edge is smaller usually. Again, we don't see any dissections at the distal edge, so that's good. This is just some blood swirling around the catheter. It's not a dissection. So that's the M done, which is okay. A is for apposition. So the OCT software comes with automatic detection of apposition. So if you turn on the rendered stent and apposition indicator, it tells you the red dots that you see here on the rendered stent indicate malapposition of more than 300 microns. Yellow dots, malapposition of between 200 and 300. And I believe you can change these settings if you like. So, but by default, this is what it is. You can turn the stent around to see where it is, where the dots are more concentrated. So we come to this area over here. So you see there are some, because the vessel or the lumen is eccentric, there are some areas where there is a bit of a malposition between the stent struts and the vessel wall. Again, not large amounts, just restricted to that one little quadrant over there. I personally think this is probably okay to leave, but we can see what the rest of the panelists think.
So we'll take a pause here. Anuruck, you presented the MLD max, and is this a good finishing result? Will you go for a compliant balloon at the proximal edge?
No, because the area is okay and the length of the malposition is not long enough. So you have to know when you deal with the calcified lesion, you have to know the limitation of all things, because if you're more aggressive, it will cause the tragic story at the end of the result. So I think this is acceptable because it's not quite a long malposition, because we have to measurement the length of the malposition. And if we cannot correct because it's long enough to live like this, maybe you have to use the medication like the longer dual antiplatelet, or it depends on what you believe, or add the compass atlas protocol, Saluto 2.5 milligram BID. It depends on what you believe that it can prevent the stent thrombosis or adverse event.
Thanks, Anuruck. Singo, will you give this a pass?
Absolutely, it's a very good result, and the dissection is limited to intima and not extending to media or less than 60 degrees. And also, as a malposition is in a short segment, and I don't think it's significant. And also the expansion looks very good, more 100%. So I would probably accept this result.
Thanks, everyone. Any other teaching comments from my panel?
Jack, can you still hear me?
Go ahead, Chiang.
Yeah, just to mention again, obviously when we see these automatic things that are generated by the computer, we also have to double check them. So for example, sometimes you see red dots here. So here, this is an artifact. This is a misinterpretation of the machine, thinking that this is a malposition when it's not. So you still have to double check that, obviously, frame by frame. Just moving on to the expansion part. So this is again, if you set your limits up here, as I'm doing, to the stent edges, the software comes up with an automatic. If your blood clearance is good enough, it comes up with a very accurate assessment of your expansion. So it splits your stent into half, and then it measures the minimum stent area in the proximal half and compares that to the proximal reference, and gives you a percentage. So in this case, it's 100%, which means that our stent is well expanded. Likewise, in the distal half, it will take the MSA in that distal half of the stent and compare it with the distal stent edge. And as you can see here, it's 123%. So that's again very good. So we are aiming for more than 90%, ideally, more than 80% if you really cannot do any better. So yeah, okay.
Thanks, Chiang. So that was actually very good. It's a pity we didn't get a chance to have Dr. Pham and Dr. Chin narrate more on some of the OCT stuff. Maybe we have opportunities in the future. Congratulating the CareFlap team for a good job, and thanks for showing us the case today. Unfortunately, I only have really the last 10 minutes to have our finishing lecture. So we want to quickly move on to Eng Han.
Right, thank you very much.
Sorry.
Thank you.
Thanks a lot,
Thank you.
Dr. Chin, Dr. Idu, Dr. Pham, and of course the patient for agreeing for this live demonstration. So I'm so sorry, Eng Han. You're
no
good
problem.
to go?
Yeah, I will share screen, but I can't share screen yet.
So we'll stop share here.
Thank you.
Okay, go ahead, please.
Okay, all right. Okay, once again, thank you very much for having me here. Are you seeing the slideshow? Yes. Okay, and congratulations on the cath lab, Jiaming and Chiang, for such a nice demonstration. I am Dr. Lim Eng Han. I'm interventional cardiologist in Mount Elizabeth Hospital in Singapore. And today my talk will be on IVUS versus OCT on calcified lesions. Does it matter? This is a lot of studies looking at the predictors of DES failure, specifically early stent thrombosis and risk stenosis and major adverse cardiac events with DES. And the topmost important reason for DES failure is underexpansion of stent. The second most important reason for DES failure is age problem, particularly those caused by geographic miss. Severe calcification is defined on radiography as of the stented artery as more than 70% of the stent segment. As seen here, it is extensive calcification is responsible for both early and late events. For early events, you can see uncovered stent struts over here, which is the reason for stent thrombosis. And for late stenosis, in this case, we could see severe medial tear because of the extensive calcification of vessel, as well as under-expansion of stent. Angiography alone is only moderately sensitive for detection of extensive calcification, with a sensitivity of 60% for a 3-quadrant calcium and 85% for a 4-quadrant calcium. Because of this, and because of the fact that angiography underestimates calcification in a lot of cases, angiography also tends to underestimate vessel size and stenosis severity. The use of intravascular imaging when we treat severely calcified vessels is extremely important. It will allow us to predict the need for debulking of the lesion to avoid angiographic mismatch, which results in underexpanded stents. Coronary calcium is a predictor of worse outcomes, and this is a comparison of the appearance of intravascular ultrasound compared to OCT and looking at deep calcium, which you can see very clearly on OCT, superficial calcium seen as a hyperechoic region with shadow behind it, concentric calcium in IVUS and OCT, this is eccentric calcium, and calcified nodules. I want to make special mention of calcified nodules, which may present with difficulties in stent deployment, stent expansion, and perhaps even cause problems and complications of vessel dissection, vessel perforation, and burr entrapment. This is how nodular calcium looks like on IVUS and OCT. So imaging is, in short, critical for decision on the choice of strategy for intervention. For superficial calcium or thin calcium, balloon angioplasty and cutting or scoring balloon may be sufficient to for vessel preparation. However, for deeper calcium and thick calcium, plaque debulking techniques using rotational atherectomy, using orbital atherectomy, and shortwave intravascular lithotripsy may be required. I'm going to compare and contrast OCT versus IVUS in the 3 areas of pre-PCI planning, stent implantation, and post-procedural assessment, starting with pre-PCI planning. Both IVUS and OCT provide us with a calcium scoring system to help us guide vessel intervention. The difference in between IVUS and OCT is both of them are able to demonstrate calcium arc, but the difference is only OCT is able to show us deeper penetration into the lesion to allow us to measure thickness of calcium and therefore area and volume of the amount of calcium surrounding a vessel wall. This looks at OCT calcium score, which is key to predicting stent expansion, looking at the 3 things of arc of calcium more than 180 degrees, thickness of calcium more than 0.5 millimeters, and length of calcium more than 5 millimeters, with a total score of 4. The higher the score, the higher the prediction of poor stent expansion and the need for plaque modification. This is a pullback of the OCT in a highly calcified LAD, showing that detecting calcium severity. There's deep calcium, superficial calcium, and also presence of nodular calcium over here, and circumferential calcium identifying Netkin ring calcification. So OCT gives a lot of information regarding the calcium calcium characteristics, which IVUS does not, and allows us to predict whether the use of rotational atherectomy or orbital atherectomy is required. In this case, the calcium length is more than 5 millimeters. The calcium thickness is more than 0.5 millimeters, and the calcium angle is more than 270 degrees, and giving a score of 4 and predicting the need for a plaque modification. Similarly, IVUS also utilizes calcium scoring to predict stent expansion. The difference is IVUS calcium score is utilized in only if the maximum calcium of more than 270 degrees is present in the vessel, and looking at circumferential calcium, presence of calcified nodule, and a small vessel diameter. It also ranges from 0 to 4 with a calcium score higher than 2, predicting the need for atherectomy. So this is an example of a highly calcified RCA looking at circumferential calcium and the presence of a calcium nodule in a vessel with length of calcium more than 5 millimeter, subtending more than 270 degrees, predicting that this vessel needs to have atherectomy to facilitate stent placement. This is how superficial calcium looks like on intravascular ultrasound. This is how deep calcium looks like in a calcified nodule. And during angiography, if the presence of angiographic calcium is present, during IVUS, we would see a lot of calcium. When IVUS is compared with OCT, the presence of smooth surface on the IVUS with reverberation predicts and correlates with thin calcium. The presence of irregular surface without reverberation indicates thicker calcium, but it is not 100% correlation. IVUS does have other utilities in that the position of the IVUS catheter and the IVUS bias actually can predict the increased risk of coronary perforation if you rotablate near a normal vessel, and suggests that changing wire bias using an extra support rotor wire may decrease the risk of vessel perforation. In terms of the differences during the process of stent implantation, first we look at the data. Calcium fracture achievable after using plaque modification techniques results in a larger stent expansion and lower rates of stenosis and TLR. And because of that, we look for calcium fractures when we modify calcified lesions. It is clearly seen using OCT. You can see multiple calcium fractures over here in this calcified vessel. OCT during stent implantation, as was demonstrated earlier in the live case and during some of the case presentations, OCT is used to select landing zones and to size the stent that's been placed, avoiding possible thin cap fibroatheromas and avoiding implanting stent where the plaque burden is high. Similarly, for IVUS, calcium fracture can also be seen. So we look for reverberation. If you look at all the blue arrows, that's where calcium fracture has occurred. When calcium is fractured, the vessel structure behind the plaque becomes visible. Okay, so these are where there's reverberation and presence of calcium fracture. So when utilizing IVUS to guide stent implantation of highly calcified vessel, always confirm the presence of reverberations before stent placement, because that signifies calcium fracture on IVUS. Now, finally, we look at post-procedural assessment between comparing OCT and IVUS. Both of them have utility in guiding stent diagnosis of stent under expansion, edge problems like dissection, geographic miss, and also for both of them, we will be looking out for malapposition and eccentricity of the stents that's been placed. There's some minor differences in terms of the utility of OCT and IVUS in post-stent assessment, in that the resolution for OCT is much higher, and therefore we can see dissection very clearly, and definitely extra stent needs to be placed if dissection penetrates medial level, medial layer, and subtends more than one quadrant arc. And for stent apposition, malapposition requiring higher size ballooning is required if it is more than 300 microns from the wall, subtending longer than 3 millimeters. And as for stent expansion, we try to go for at least 80% expansion. So in terms of diagnosis of dissection and stent expansion, it is similar for IVUS. The only difference is in stent malapposition. In acute stent malapposition in IVUS is defined as separation of at least one stent strut from the internal surface of the arterial wall that's not overlapping the side branch. So this is an example of stent malapposition, which is insignificant because it measures only 170 microns, which I've mentioned earlier that it's easier, that it's commonly seen if the vessel is highly calcified. So I would like to summarize that I have compared OCT versus IVUS in terms of pre-procedural planning, stent implantation, and post-procedural assessment. Some of the differences have been presented. Now we look at data, the final few slides. There's a lot of data on IVUS in terms of markedly decreased major adverse cardiac events and target vessel failure when used IVUS guidance compared to angiographic guidance at 1 year and then further out to 5 years in these two trials, IVUS XPL and Ultimate. There is also mortality benefit of 40% as shown in this table, which summarizes all the trials that's been done through the years, comparing IVUS guided PCI versus angiography guided PCI. So there is evidence in using IVUS guidance. Now, Opinion trial is a randomized trial of IVUS versus OCT guided DES implantation in about 800 patients, showing no difference between OCT guided PCI compared to IVUS PCI. We now await Aluminum 4 to give us some data on the advantage of using OCT guidance. So the key messages I would like to summarize is that intravascular imaging should be utilized for decision-making regarding PCI therapy. Both OCT and IVUS use following lesion preparation allows the recognition of calcium fracture and whether further lesion preparation is needed. Never implant a stent unless the lesion is fully dilated, and always use multiple, there are multiple choices of plaque debulking device is available, and for stent optimization. And the most important point is a small MSA is the most common predictor of stent failure, and the use of intravascular imaging can also minimize complications of dissection, perforation, and burr entrapment. Thank you.
Thanks, Sengkang. Thanks for putting it at the spot to provide so much summary of the last minute. We've overrun time, so before I thank my panelists, I see a lot of questions. I'd like to just go around my panel to ask you to commit to 4 scenarios, provided you can diagnose the type of calcification of OCT. The 4 scenarios is thick concentric calcification in large vessel, thick concentric calcification in small vessel, eccentric thick calcification, and calcified nodule. Tell me, what is your intervention strategy? Is it balloon, rotational, OAS, lithotripsy, or don't know? Okay, so we'll start with Anuruck. Anuruck, for thick concentric calcification in small vessel.
Thick concentric, so I use the rotablator.
Okay, rotablator, thick concentric calcification in larger vessels.
Larger vessels, so prove with the physiologic first, because you cannot get the good result with the heavy calcifying.
So check first. Eccentric heavy thick calcification.
Again, try to avoid to do that because it's usually the calcifying nodule, so you cannot get the good long-term clinical result with this finding.
So try to avoid. Calcific nodule.
Same. Try to avoid.
Donnie,
we have to do the big MSA after we do.
Thick concentric calcification, small vessel.
For me?
Yes.
Okay, yeah. I'm a big fan of physiology study. So most of the time, the long lesion, small vessel, you don't need a stent anyway. So, but anyway, if you need to do something, rotablator is fine in my preference.
Okay. How about large vessel?
Yeah, after the physiology study, maybe I would use orbital atherectomy. It can create a large.
So I presume for eccentric and calcific nodule also FFR first. Donnie's answer is FFR first. So thanks for those answers. Single, I'll come back to you. So for thick concentric small vessel.
Yeah, see, when there is a lumen uncrossable vessel, both orbital and rotablation will work. But you have to remember that the interface in the rotablation is at the tip. So whenever you have crossing difficulty, rotablation would be the best option because orbital has the interface at the crown, which is about 6.0 millimeters distal to the proximal tip. So one has to remember, if it's a large vessel with concentric lumen as well as small vessel, if you have a very tight lesion, rotablation is the first choice, particularly in a smaller vessel with concentric calcium. But if you have a large vessel with a concentric calcium, orbital will be considered because rotablation burr may not reach the surface, so orbital will be a much better option in that situation. In an eccentric calcium, one can consider preferably orbital. Sometimes IVL can work, the shock wave, but more often it is the orbital will be much better in eccentric calcium. In the other situation was a nodule. Nodule is again very challenging to treat. Sometimes even a plain balloon would work, or sometimes an IVL balloon would work because it depends. One has to check with the balloon and then see how the response is and decide. Having said that, there are some situations like ostium where we prefer a shockwave balloon because the risks of other therapies are more riskier compared in a left main ostium or an ostial circumflex.
Excellent answer, Sengo. Alan, your take on these 4 categories.
So for for circumferential calcification in small vessels, so I would usually choose rotational atherectomies. The same reason mentioned by other speakers, right? So orbital, sometimes for very small vessel, most of the time is very tight and occlusive. So the orbital may not be able to cross this very occlusive calcified lesions. So for big vessel and concentric calcification, for my choice, usually maybe shockwave in case you can able to pass the shockwave balloon. Big vessel usually for me is like 3.0 or above. So shockwave you can have up to 4.0 shockwave balloon. Again, it depends on your local availability. So I think for big vessel, shockwave should be most of the time should be the first choice. Particularly you can able to pass the balloon. So for eccentric calcification, I think the imaging, particularly OCT, will come into place. You're able to see where is your Y bias, right? The Y bias is especially important because most of the time it's a Y bias to guide whether you can atherectomize the calcium. I think the same scenario applies for calcified nodules. So sometimes you may need different tips and tricks to alter your Y bias, right? So for example, in rotational atherectomy, you may use this again a huge talk. You can many maneuver to change your Y bias. Like you use the rotor extra support. You may use the different guiding positions. You may use different speed. There's a talk by a Japanese expert with excellent scenario. So of course, sometimes you may need to use combination therapy for those eccentric calcification. So I saw
Alan. Yeah. Again, very strong teaching points. We'll leave the last word to Prof. Akasaka. Anything at all that you want to finish up?
Yeah, thank you very much, Jack. Yes, as I almost agree all the Alan's comment, right?
Almost, yes.
Yeah, because thick concentric calcium, we prefer to do the rotablator because if we select a orbiter, when we use an orbiter, we need some space. If there are no space, it might be difficult to rotate, right? So, and thick concentric large vessel, if balloon crossable shockwave should be is ideal, but if it is not crossable, first we try to do the rotablator, and then but if there are some space, orbital atherectomy can be used, right? It might be okay. And eccentric thick calcium, as Alan said, the wire bias is very important. And if we can use the wire bias, the orbiter might be the ideal, right? And also the position of the calcium is very important. If the calcium is the myocardial site during pullback orbiter atherectomy might be effective, but epicardial site during push in we can make an ablation, right? And also the calcific nodule. There are two types of calcific nodule. There are some, yes, we need some consensus. Nodular calcification is a very stable condition. At that time, we try to use orbital atherectomy. But calcified nodule is some mixture of the rupture, and I think at the moment, laser atherectomy might be the most effective at the moment, I think. That's
Thanks.
all. Yeah.
Thanks, Prof. Again, the master Sensei has spoken. He finished up with the last word. So it's beholden to me just to thank all my panelists and the Cath Lab for the wonderful job. And I really learned a lot today. I wanted to spend more time just narrating, going through each segment properly. But again, you saw the limitation in time. 2 hours flies too fast. I want to thank the participants for staying beyond the 2 hours, and I apologize for it. I'll try to keep the time the next round. So do keep safe and keep well. And I hope to see everyone very, very soon. Thank you very much for your time, and goodbye.
Thank you.
Bye-bye.
Thank you, everyone. Thank you.
Bye-bye.
All right. Thank you. Bye-bye.